well, I think that we have everyone up here, and maybe just to break the ice, I'll start out by posing this question that I think that Pui raised at the end of his talk, and that is the whole question of genetic versus functional approaches to evaluating patients with DADA2. Certainly, we've heard that there are situations in which one can find patients that have clinical disease and only have one identifiable mutation, or maybe not even any identifiable mutations, but where enzymatic assays do demonstrate a reduction in function. So the question that I would pose to the group is, maybe we should change the order in which we do things, where perhaps one would want to do a functional assay first and then a genetic evaluation afterwards. Would anyone like to take a crack at that question?
I'll take a crack. So Pui's presentation was very nice. I definitely think that we need the enzyme activity as well, maybe first. And I separate heterozygotes into two. You know, the heterozygotes with a, extremely low level of enzyme activity, like 0, I would call true DADA2 patients where I'm somehow not identifying the second mutation. But the heterozygotes with, a level suitable for the carriers and with these symptoms you have shown us, I would call them polygenic disease, because we have that experience in FMF as well. We have all these heterozygotes who display some interesting inflammation. That's not always, 100% FMF phenotype. So I think they are more like polygenic patients where, the mutation in DADA2 is obviously contributing. So I separate them in my mind. But I definitely think that we need the enzyme activity, and we cannot confirm the diagnosis without the enzyme activity as well. Thank you.
Does anyone else want to comment on this? Mike, do you want to comment on the availability of, the practicability of widespread testing?
Well, we're going to have a lot more labs that do the testing.
Yeah.
But I think, some laboratories and some patients in some parts of the world may have access to sequencing, and there's no harm in sending out the sequencing to be done while you're waiting for the answer, getting enzyme activity. But the problem is there are a lot of things that look like DADA2 clinically. And, we get two kinds of samples from patients who are known to have at least one mutation, if not two. And then we get samples from patients who are suspected of having the clinical disease and no information about mutations. And really, as you might expect, the second group, most of the patients are not deficient. I can add to what Pui said. We have tested a couple of patients recently, young women in their mid-20s who've had symptoms for over 10 years, who turn out to be in the carrier range. And I think that's a very real concern. My feeling is that anybody you strongly suspect, though, should have functional testing. I agree with Cesar.
Well, but then to get to my question, how easy would it be to implement, testing
in some parts
more
of the world,
broadly?
it's been implemented almost since ADA2 was discovered. In large parts of the world, the reason for testing for ADA2 is to distinguish an effusion from a patient with tuberculosis, which is common in lots of the parts of the world, much more common than in the US, from other kinds of problems that can give you an effusion, measuring both plasma and effusion in some places. So in some parts of the world, I suspect Turkey, you've already have laboratories that measure ADA2 activity. They may not have ranges established for carriers because they're looking for high levels. We can do the assay on dried plasma spots from patients around the world, and we do. Most of our patients that we send for testing are not from the U.S., where we test plasma. There are these dried plasma spots. And the only reason I'm confident in the results is because we're looking for absence of activity. It turns out we can pretty accurately distinguish carriers from healthy controls or deficient. But I really think laboratories around the world that already do ADA2 testing are going to have to reestablish ranges for patients with DADA2 and carriers. And then it could be done in lots of parts of the world easily.
Mm-hmm. Marcin, you wanted to say something?
I find there is a considerable difficulty in also counseling the families who have heterozygous mutations. So for us, I know of 3 patients with de novo diamond blackfan anemia who have heterozygous missense mutations. The activity of the enzyme is in the range of heterozygous carriers. They have whole exome sequencing performed, and nothing was identified besides those heterozygous variants. And we told the families, they asked us, is it pathogenic, is it causing the disease? We told them, based on the observation, that all the other parents of our patients with diamond blackfan anemia who had the phenotype of pure red cell aplasia due to DADA2 deficiency, that all the other carrier parents were normal. Based on that observation, we told them it's probably not causative. But now I think I have to rethink the strategy. So will the in vitro testing help me? I don't know, maybe, yeah.
Mm-hmm. Other comments?
Just a point related to the importance of the clinical manifestation together with genetics, and it's obvious, but of course there are some patients that really resemble a DADA2. I show you some patients that in which, of course, the triad was present, vasculitis, strokes, hypogammaglobulinemia. I mean, it's completely different. And also in your cohort, small cohort, there are different patients. That one with a big hemorrhage is very worrisome, and I would treat like a DADA2, but the other with a PFAPA, it's completely different. So this aspect should be considered very carefully. It is obviously.
I think getting back to the availability issue, I think, at least I can speak for outside of the US. At least for the US, there are a few places that most commonly are done, mostly through Mike's lab, who is clear certified, and NIH can do it on a research basis, and we can also do it Boston on a research basis. But I agree that I think probably we have to be able to get a company or some standard lab to be able to do this, so where anytime a clinician out, not one of us here, but if people are less aware of this, who can just send this test easily without having contact through multiple levels.
Do you think that it would make sense as a to-do item from this meeting that perhaps we should try to engage one of the large clinical testing companies to take this on as something that they would do, at least in the United States and possibly in other countries, as a test that could be reported back to patients. In the United States, that's called CLIA certified, but other places it may be something else, so that it would be more broadly available, and it wouldn't be just a matter of either sending it to Mike Hirschfeld's lab or to some other research lab that you happen to know would do it for you. Yeah, Taryn.
So I can see 2 separate issues here. One is that I think the testing of the enzymatic activity in the acute setting of a young child with a stroke or with a bone marrow failure, I can see that that would be a very, very helpful situation, because when I've done it at the Institute of Child Health in Great Ormond Street, it's a very quick assay and you have the result very fast. So I think that we should be evolving that as a community. I'm a little bit concerned that we don't have the age range exactly correct, and that perhaps when we have many more hundreds of assays and hundreds of patients that we've assayed, that perhaps our ranges will change, and I'm a bit worried that we will be over-diagnosing people potentially, or even underdiagnosing, or we don't yet know how to interpret it because we don't have a range for it at every single age of life.
Yeah, and maybe just to be a little bit provocative with regard to the levels and ranges, these are just based on an enzymatic activity in an assay. And since we don't know exactly what it is that ADA2 is doing, it may be that there is some essential function that it has that is somehow not quite captured by the assay. It's sort of captured by it, but may not be exactly addressed by the assay.
Yeah, I would agree. I mean, that's the difference between ADA1 deficiency and ADA2 deficiency. We always measure enzyme activity and deoxyadenosine nucleotide levels. And each one of them has a p-value of like 10 to the minus 25 or something like that in making the diagnosis. And it's also, why I think we're probably doing, a metabolomic screen in the hopes of finding something with, my suspicion is we won't, but if we did, that would get more perhaps towards something truly connected with pathogenesis, whereas the enzyme activity, I'm not, I think the ranges are pretty good. I'll say one thing, and I agree with Taryn, that age ranges for the activity should be better defined. I think Pui is going to be able, he has a research study, and he can look at normal, healthy children. Nobody sends us control samples from children. They're always from healthy adults. So we don't have a good range for that. But I will say that in patients who clinically look like ADA2, who are sent to us for testing and are not ADA2 deficient, the levels tend to be about twice as high at least, and up to 10 times as high as the healthy adult control ranges. So that also helps you distinguish when you're sent a sample from a patient who has some inflammatory problem. Their levels are likely, if they're not DADA2, going to be high. All bets are off in carriers, though, because they have one allele that could go up.
Yeah.
We have had, we tested true polyarteritis nodosa patients and a few controls, children, and they were high, they were normal. So we had the ranges for the children.
Erica, I think you wanted to say something.
Yeah, another aspect is that the enzyme activity levels don't always correlate with disease activity as well, seen as we saw from the pre-symptomatic or the asymptomatic patients, like even in the family I presented, the ADA2 enzyme activity is completely similar to the brother who is diseased, but yet he has no symptoms. So I think that also makes it more complex again.
Yeah, well, it goes to that point that I was making, that maybe there is some other thing that needs to be measured, that the enzyme activities that we do approximates that, but it may not address it in every case.
Well, I'm sorry.
Yeah, Mike.
I just have one question to Mike. So we know from some other autosomal dominant disorders that there can be a differential allelic expression. So basically, for example, it has been shown in DADA2 deficiency that the Y type can be silenced, for example, or and only the mutant expressed. This is due to differential epigenetic regulation of the alleles, so either through hypermethylation or through histone modification. So my question is, has anyone ever looked at that in ADA2 deficiency, if the alleles can be differentially expressed? First question. And second question is, if you look at the heterozygous carriers, in the scenario, this is just a theoretical scenario, in the scenario when the Y-type allele would be silenced, would you see a decrease in ADA2 activity on your assay?
So I can't answer those questions. It's very interesting. Pui might be able to comment on that. I will say that the idea that ADA2 might be, I don't know if you call it a growth factor, but something that affects polarization of macrophages is very real. And there is, Anton may talk about this, but if we knew what the receptor was, we may find patients who have problems with the receptor in levels or something else that could show up. Also, yeah.
That are eager for asking questions. Okay, but why don't we just finish this little discussion first? Pui, you wanted to...
So I think so I don't know the true answer to your question particularly. I'm sure there's a lot of different genetic variants, allelic expression discrepancy that may explain the heterogeneity here. What we have done is that we have measured this in healthy children and adults through multiple collaboration of getting blood samples from vet screening and rheumatology patients who are not diagnosed with rheumatology disease. We have cohorts of healthy donors right? And also for adults that are blood donors, essentially we get discarded blood, where we have a wide range of ADA2 measured. And in general, you see a decline over time in age, but there are plenty of overlaps between each age range. So there's no way you can predict the age of of the person looking at ADA2 level, because certainly as you get older, the older adults have lower level on average compared to a child, for example. But there are adults that have high levels, there are child with low levels. So it is significant in terms of drawing a correlation, but it's not predicted by any means.
All right, well, wow, my goodness, there's all sorts of people raising their hands there. So, well, just to start in the front, Helen, do you want to take it away?
One comment and then a question. In my salad days, I merrily measured soluble TNF levels and then stress tested patients almost to death by giving patients with traps infliximab. And I'm extremely nervous about functional testing if we don't have a pathophysiology, because boy, did the traps is quite a bad story about a very neat story that in the end wasn't quite right. And so I would again sort of stress, are we sure that measuring enzyme activity is the marker of physiology, of the pathophysiology of this disease?
Okay, and that gets to this question of, is there something else that needs to be measured?
And the other question, the question was, in patients with lymphoma and with myelodysplasia in adulthood, has anyone looked for somatic mutation in the tumor cells in ADA2?
So our patient were a pediatric patient. What's your question?
So non-Hodgkin's lymphoma is extremely common. Has anyone looked in the tumor cells for somatic mutations in adenosine deaminase 2 in adult Hodgkin's?
We don't look at that actually. So we looked at only in the plasma, and we discovered that after the treatment by about 6 years.
I think Helen is suggesting that one could take a cohort, though, of 1,000 Hodgkin's patients or something and look to see whether in them, even if it was only 5% of them or something like that, have somatic mutations in ADA2. That would be a very interesting and potentially significant finding. Okay, in the back, we have Carol Barron, who wants to ask a question.
So we do extensive immunologic and radiologic studies on our patients. Has anybody extended these to the parents and the sibling carriers?
So with a family of a patient initially that came from Great Ormond Street, they are very consanguineous and they have homozygous mutations and they are asymptomatic, but we imaged the parents and we've imaged both parents. One is a homozygote, one is a heterozygote. They've had all sorts of angiography. We've imaged them top to toe. There is absolutely nothing there. And I think Helen repeated it. They've been serially imaged, and another family the same, and we found nothing.
And how many have you looked at?
She's saying 5.
5.
And the immunologic studies as well?
I think they've all got low IgM, but otherwise they're normal and they don't have susceptibility to infection. But other than the father who is heterozygote, every family member is a homozygote.
When we study for the B cells and T cells compartment in our cohort, indeed, in the carriers we have a normal, in the real carriers we have normal values that was completely different from the patients. That is the only way.
I can actually shortly comment. We also have a sister of one of the LGL ADA2 patients who has the same homozygote mutation and absolutely nothing in the immunological picture of her, and she's completely healthy.
Is your screening evidence-based or expert-based? So do you do it only once? Or?
We've repeated it, but it was basically thought of from our experience of imaging adult patients with polyarteritis nodosa. These are all adult patients. Paul, these are Paul's patients. Did you want to comment about them? Sorry.
Yeah, just 2 comments to share my fear. So what we've learned is that these biomarkers that we use in routine clinical practice do not predict clinical outcomes. We have had patients have strokes with completely normal blood tests. We've had patients infarct their testicle with completely normal blood tests. And the point I just want to make is do not be reassured. We're kind of fixed in this idea of autoinflammation and what we understand as autoinflammation with high CRP, high ESR. This disease can do things at an endothelial and vascular level with completely normal imaging, routine blood tests. And when we get down to the level of single cell transcriptomics, then we'll find our biomarkers, I'm pretty certain. Anyway, I don't know what all the fuss is about. It seems very clear, coming back to the heterozygous story, that some patients, like FMF, behave like this is an autosomal dominant disease, variably penetrant and with gene dosage effect, a bit like FMF. To me, I think at the minute that's the safest model, at least in my mind, for some patients.
Yeah, and it's knowing what percentage of those hets actually then will have a clinical phenotype. With FMF, it's a large percentage, actually, but for this, it may be smaller. Gigi?
My comment is also about the heterozygous carriers. I think there is a lack of knowledge there and also probably insufficient data on the reproducibility of the enzymatic levels in these individuals. I would be very cautious in calling for enzymatic testing in all subjects until we know for sure there is a threshold below which actually there is an increased risk of clinical manifestation. I don't think we are in that situation at this point. I'm not even sure that anybody has ever run repeated tests on the same individuals over time and compared actual results. I very much like Pui's presentation because I think it raises a very important question: are we dealing with haploinsufficiency? Are we dealing with the dominant negative effect? Are we dealing with both? And this is very important to find out. And I think I liked your approach. I would even suggest to use a bicistronic vector where you co-transfect basically at the same time a wild type and a mutant form in a cell line that is completely negative for ADA2, and then do this assay for a variety of mutations. I think this is important to know, and it may actually tell us that the group of so-called heterozygous carriers, maybe they are indeed two different groups of individuals, some of which have intermediate levels, which may have no clinical relevance, and others really be dominant negative, where you do expect activity levels that are below 50%, because that's what a dominant negative does. It really brings your activity way down. Those individuals might be actually individuals to follow up. But I think we have a lack of knowledge at this point. This is something that has to be done.
I agree with you, Gigi. One thing, though, is that getting back to the point that we've discussed a little bit, is that we don't necessarily know what's the right readout, in terms of if you have the expression of a particular variant, whether or not just measuring the activity is what one needs to do, or whether there is some sort of a function that we haven't yet gotten at. Mike?
Yeah. I would say that knowing the enzyme activity is only a place to start. I think knowing that somebody's a heterozygote, it doesn't tell you whether they're going to express a problem or not. So I think expression is a whole other area. And if it's variable, there may be a mechanism responsible for that will tell you that, maybe it has to do with haploinsufficiency or dominant negative. But I think maybe in Pui's assay, if Gigi is offering suggestions for how to do it, I might say maybe what's missing, because one of the questions in carriers really is what is affecting the level of expression of the good allele, of the wild type. And so you might include, and with mutants that are of unknown significance, include something to mimic an inflammatory stimulus to see how the level then changes when you do something that, may show some alleles do not increase appropriately.
I think Pui wants to respond to that.
Gigi, that's why we miss you in Boston. So great point. I think that the bicistronic vector is a great idea. Speaking to your point about stability of measuring the same subject over time, probably not a good thing to say here, but people in my laboratory have gotten repeated measurements over the last few years. And overall, the same subject, whether they're just on a day-to-day basis, even having colds and things like that, they don't change. It's within 10% of, which is within the error of the assay. So I don't really believe that. Certainly, we haven't tested every cytokine, every stimulus, but for the most part, it isn't something that fluctuates variably a lot in the same individual.
Yeah, Troy.
So this is a question related to that. So I was interested to see sort of this expansion, the expansion of mutations. And I guess the first question would be, do you have any sense among those? There's clearly some of those that affect secretion of the protein extracellularly, but do you have any sense for what percentage of those mutations actually are made to a normal level? They get secreted normally, but just don't have whatever function ADA2 has. So that would be one question: is how many of those affect secretion and how many of them don't affect activity? And I don't know whether so that would be the first question. The second question is related to that, which is that and I'm glad you brought it up, because this was the question that arose as I was thinking about earlier talks, this idea of dominant negative activity, because if they are in fact secreted, they're secreted at normal levels, that potentially has implications if you're going to use enzyme replacement therapy, because if it homodimerizes, is that going to decrease the effectiveness of any enzyme replacement therapy for any of those that are secreted? And if you're thinking about treating this by gene therapy, then the question becomes, in those that are not secreted, is gene therapy going to be adequate because they homodimerize, and then the corrected protein, again, is activity that is decreased in a dominant negative way. So two related questions. I don't know, any input on that?
I'll try to address this first. So to the first point, yes, well taken. And so for these assays, which is 293 cells, we have done both ELISA measurement of the actual secreted protein and also as the activity. And it is really not a binary variable. You see a whole spectrum where some mutations are completely non-secretory, where they're just retained inside the cell due to misfolding or one reason or another, versus other are fully secreted, which have no activity. And we've tried to sort of correlate that clinically, right? One limitation is that we can only address missense mutations, right? Which is really hard to. Early stops and frame shift, these are not things, or splicing mutations, not things that we can do with this assay. At least from the missense standpoint, it's been hard because outside of the couple common mutations, most patients have two mutations that are compound heterozygous. And having that in mind, it's really hard to sort of make a good conclusion to just functional phenotype, as I would call it, in terms of not just a phenotype to genotype, but a functional phenotype correlation. That hasn't panned out so far, but I think that it's an important thing to address. And anyone else want to?
Just the implications for therapy. I mean, I think that they're quite substantial, potentially.
So I think there's also talks this afternoon about whether you truly need also earlier, whether you truly need do you need a protein or do you need the activity, right? Or do you need both? So we don't know that, I don't think. So until we get to that's the other part of the puzzle where, do you replace the proteins, presumably you get the activity back also? Is that sufficient? Or because once your protein's outside, I don't think you worry about the dimerization. Dimerization usually happens inside the cell. So once it's out of the cell, I don't think I guess the bad protein interact with the good protein that way.
But I mean, those that get secreted to normal levels would imply that in fact protein is not enough, right? So that it must require whatever activity ADA2 has.
Correct. I agree.
Yeah, Mike.
Just one, I'm not sure how useful it is, but at least with the mutations of unknown significance that you're expressing as cDNAs and seeing activity, one minor, like once in a million years, you'll run into a situation that we have run into with ADA1, where you get a missense mutation that is predicted by 10 different, computer programs that is going to be bad. And you express the cDNA and you find out it's got activity, like 80% of wild type or wild type. And then you realize that the mutation is very close to a splice site. And then you get the patient's cells and you see that it's affecting splicing. And that may not explain some of them, but.
Okay, I think there's a question in the back.
So I want to thank Marcin for showing my picture. I'm Blanche Alter. But I'm coming at this from the world of hematology, not the great world of data and immunology. And one of the thoughts I had, as I understand from one of the comments, there's more than one cell type that expresses this enzyme. And the variability, particularly in the heterozygote, may depend on the blood that's circulating on the day you're taking the plasma, in terms of are there more lymphocytes, or are there more monocytes, or are there more granulocytes, et cetera. And some assays that we do require cell separations to really understand what's going on. And the second comment is that, as I understand it, there is an assay where there are cells into which you can put the gene you want to understand. And so that would solve your biallelic, which is you'd put each targeted gene into those cells to see what its function is. Just some hematologic thoughts.
So I largely agree on those points in terms of the functional assay. I think it does add an element to, in addition to the genetics and also the activity assay. It's not a difficult thing to do per se, but it only really addresses the missense mutations. And as Marcin's alluded to, at least in the patient with the hematologic phenotype, he's often finding frame shifts and early terminations where presumably the protein is absent, unless there's an argument where that the front part may have some domino negative effect or partial effects that's not be able to address using the same approach.
Helen.
I'm fascinated that anti-TNF seems to help the hematological phenotype as well as the vasculitic phenotype. And I wondered whether that was an angle into trying to understand what's going on and whether anyone's done gene expression studies in a fairly non-targeted fashion in both the vasculitic patients pre and post-treatment and the hematological patients pre and post-treatment, and whether there's any shared patterns.
So Ivona, don't you have some data on that?
So what we've done is basically to look at the level of skin biopsies from patients before and after the treatment, and I showed one of the slides in my talk where we had evidence for tissue level inflammation. So we observed high production of IL-1, TNF, etc. In the same tissue, you don't see really preserved vessels. So they're just not there, or they're hard to detect. So that means that inflamed tissue really results in sort of destruction of blood vessels, integrity of the blood vessels. And then we got skin biopsies from the same patient, although there was a limited number of those patients or other patients who were treated with TNF inhibitors for a while, and look at again to see whether we see expression of pro-inflammatory cytokines in these biopsies and what is happening with their blood vessels. By using a marker for blood vessels, CD31. So what we observed post-treatment with TNF is that basically TNF cytokine is not there, it's not present anymore in this tissue, and you can see that blood vessels basically regain their morphology and integrity. So the way how we interpret this data is that the reason why we see vasculitis in these patients is really the consequence of the inflammation at the tissue level. And the TNF treatment helps with that. So that's probably the reason why we haven't observed, at least in our cohort of patients that have been treated with TNF inhibitors for now many years, not a single case of a patient who presented with strokes. I cannot address the question regarding hematological features that are seen in many patients with DADA2. First of all, we don't see that many patients with bone marrow failure and severe anemia in our clinic, and just for the fact that we are a reference center for patients with inflammation, we see more patients that present with inflammation, PAN kind of phenotype, and these sort of things. So yeah, that's what I can tell you. So I think that the treatment with TNF definitely helps restores the integrity of blood vessels, and that's the reason why we don't see recurrence of strokes in these patients.
So in our cohort, there were 2 patients with the red cell aplasia phenotype only. They had been treated with TNF alpha and did not benefit from that, so nothing changed. I know of 2 other patients with pure red cell aplasia who also were treated and did not improve. So for my patients, I would suggest upfront transplantation, unless there is more data.
Mandy?
And I've just seen 2 patients, so I'm far from an expert on the DADA2, but yet our one patient who's had a response, a good response, and then the other one has not had a response. He's still neutropenic. I do find it interesting that, you know, some idiopathic aplastic anemia patients have had some, you know, elevations in TNF-alpha. We actually have a severe idioplastic aplastic anemia patient that we worked up for DADA2 and it was negative, but she has responded to anti-TNF therapy despite not responding to ATGAM and cyclosporin, and the family didn't want to go to transplant, so we tried anti-TNF therapy and she's actually responded to that as well too. So I feel like there's some we're kind of unclear of kind of the etiology behind the hematopoietic kind of difficulties we're seeing in some of these patients, whether it's intrinsic or extrinsic, but there, you know, is it just, you know, the TNF-alpha in some of the studies they've looked at aplastic anemia patients that they feel like it kind of drives the hematopoietic stem cells down an apoptotic pathway. Are you somehow changing the inflammatory milieu of the bone marrow so it's less inflamed too? So it's kind of unclear, but I think it's interesting. I feel like anti-TNF therapy versus transplant, I feel like, you know, it's hard to say right now. Maybe use it as a patient-to-patient situation. If a patient has good transplant matches and doesn't have any significant comorbidities, potentially go down the transplant route. But if you feel like they don't have good donor sources and don't have great comorbidities, potentially trying TNF-alpha inhibitors might be an option in them as well. And I think the malignancy risk is kind of going to be interesting to pan out if there's, you know, we find that there is more of a malignancy risk with some of the other bone marrow failure syndromes where they have a AML or MDS risk, not just like a lymphoma risk, that potentially moving towards transplant would be an option once we kind of figure more about the hematopoietic stem cell kind of pathophysiology too.
Mandy, why don't you go first and then Marco?
I just wanted to comment on Helen's question and comment in the fact that in our cohort at the NIH, we have seen what has kind of just been said here, that pure red cell aplasia aplastic anemia doesn't really seem to respond to TNF blockade. And interesting to note, which is follow-up to Dr. Mishniaki's, is that we repeated a bone marrow on his patient who has normalized his blood counts on adalimumab. And what we have found is actually his marrow is just as empty as it ever was. He has the significant bone pain that was remarked upon there is actually, we did a PET scan and saw increased uptake in the long bones activity there. So we're thinking that he's just got some more of an extramedullary, like in different areas. He's producing some blood, which is amazing. But the one very appearing, and you're going to hear a lot more about this from Kathy Calvo sitting next to me a little bit later, is that the neutropenia that we're seeing in these patients does seem to be a very immune-mediated neutropenia. And that is where I think there is a lot of room to potentially find additional treatments that can really target what appears to be a CD8 lymphocyte attack on the maturing neutrophils. And I think that is the one where there is much potential for maybe not anti-TNF because it doesn't seem to really hold it all the time in all our patients, but some sort of treatment to help with that.
Okay, well, thank you. And anyone that has their light on with their microphone, please turn it off because we can only have 3 on at a time, or else we will have probably a fire alarm or something like that. Marco.
No, my comment was just very, very obvious. The fact that this is really a gray area of the DADA2 story, and of course we should ask to our hematologist friends to go a little bit more in deep in this because I think we lack a lot of things about the pathogenesis of DADA2 in general, but now we start but in this kind of aspect we have still some emotions, some feelings, some patients that respond, some patients that do not, and it would be very nice that if someone have an idea how to study this problem.
I just want to bring up an anecdotal case that has not been published yet. It's from Italy, from Carlo Dufour. It's a young adolescent, young adult patient who, with DADA2 deficiency who suffered from pancytopenia and vasculitis. She did not respond to TNF-alpha blockade, but responded to sirolimus.
Troy.
This question is really for Dr. Izawa and for Marcin. So I was intrigued by, so both the zebrafish and the iPS cell studies. So the zebrafish, it would suggest that in fact this is not a cell intrinsic problem. The iPS cell studies would suggest that this and is more of an environmental microenvironment problem. But I would love to hear your thoughts on that and what you think might be the other cell types that would be involved in the aplasia that you're seeing.
Okay. We tried twice with a DADA2 patient, but it seems normal. I mean the percentage and also the number, and also we look at the microscope, it looks fine. So, as you mentioned, probably not only the erythroblast, but also the other environment may be important, but we don't know. We tried with other disease, and there's an absence in the erythroblast with pure cerebral aplasia. I forgot the gene, but so I think our protocol is working, but in DADA2, it's not. Maybe it's not only the erythroblast. Maybe the environment is important, or maybe our protocol is not good enough, but we don't have the answer yet.
I cannot understand how it happens. What I can tell you that when we purify CD34 cells from 3 patients, we put them in culture, try to grow erythroid lineage out of it, it doesn't work. So somehow, the way we try to explain it, maybe it's maybe those CD34 cells from the patients had already been exposed to some stressors and they're already altered. So maybe this is the extrinsic effect, but certainly it's not the extrinsic effect coming from during the culture from monocytes, because there are no monocytes in there and there is no activity of the AD2 probably. Or maybe this is some adenosine accumulation and toxicity from adenosine.
So, Marcin, I think we sent you some ADA2, some recombinant ADA2. Did you add it back to the CD34?
Not yet, because we don't have any more CD34 cells.
Okay,
that's a problem.
Well, we'll send you fresh enzyme.
Dr. Young.
So there was a kind of a call for hematologists to step in, so I'll step in. There's a paper we have in press. In Blood, you can find it online, in which the role of TNF in an immune model of murine marrow failure. Surprisingly, TNF in macrophages appears to license T cells to produce gamma interferon, a mechanism that was a surprise to us. And the macrophages in patients with aplascanemia, idiopathic aplascanemia, in fact, have a lot of TNF in them, which is not perhaps entirely surprising. The other comment I'll make is that DADA2 is not in the genomic screens, so that the commercial and university academic screens for bone marrow failure syndrome. And obviously, this very good conference has inspired me to go back and look at patients who we've seen who occasionally do have livedo-reticularis or evidence of vasculitis. It's been puzzling. Hypogammaglobulinemia has been a feature of especially some children with aplascanemia. It's been something we shrug about, but I suspect there's buried DADA2 patients, maybe in fact literally, in our aplascanemia database.
Yeah, yeah. Okay, we have a question.
So this is a pretty simplistic question, and I'm sorry for putting my rheumatology colleagues on the spot, but in other diseases that affect blood vessels, we look at capillary microscopy. I'm wondering if anybody has systematically looked to see if we can see other sites where blood vessels are not functioning normally.
I tried. I have the capilloscopy in my office, and I never seen something special in this patient. I mean, at least in my.
There's a question.
I haven't either, but it affects the medium-sized vessels mainly, so maybe that's why.
There's a question in the back.
I'm Gadir Sasso from Texas Children's, and I have 2 questions to Marcin and probably a comment. But my first question is whether or not you've noticed lymphocyte aggregates in the bone marrows of those patients that you did find to have DADA2. And my second question is whether or not you've considered looking at those that have had spontaneous remission of their DBA as well. And my comment is more about, like, do we really have to call it diamond blackfan anemia? Because it does feel like it's a distinct entity where it's normocytic anemia, can happen anytime. It's not associated with elevated EADA or fetal hemoglobin, and they kind of feel like they own their own distinct entity. So why not call it pure red cell aplasia and leave it at that?
Okay, thanks. So I work backwards. We had a guideline conference several months ago where many countries were involved, and we decided that ADA2-related red cell aplasia is a phenocopy of DBA. It's not DBA. So this is point number one. Point number two, regarding the spontaneous remissions, we have not seen any, and we would not expect any, at least based on the data that we know of. Other patients with ADA2-related red cell aplasia, once they become transfusion dependent, they remain transfusion dependent. Again, at least in our pediatric population. So we would advocate for early upfront transplant. And the question number one was, sorry?
Is whether or not you've seen anything pathologically on their bone
not
marrows.
really. There was only one patient with eosinophilia, but I think, Blanche, this is quite unspecific, right?
So my question
Yes.
kind of, yeah, my question comes from our own experience where we've had 2 patients who seem to have lymphocyte aggregates, and I guess our hypothesis was that maybe there is some interplay between T cells and macrophages are so essential for erythroid lineage, and so perhaps that's the etiology of pure red cell aplasia. So I was curious.
Yeah, and our patients that we commented on, they both had lymphoid aggregates. The first patient that had more significant pancytopenia, he had more impressive lymphoid aggregates, and I know going through the literature search when I was writing our publication, I found a few, not many papers commented on bone marrow pathology, but there was a few, 2 or 3, I believe, that had commented on maybe seeing some lymphoid aggregates as well.
Dr. Calvo, do you want to comment?
Yes, at NIH, one of our patients with pure red cell aplasia and DADA2 had markedly increased T cell infiltrate in the marrow with T cell aggregates, but that patient had also developed neutropenia at that time.
Can I just ask whether red or lymphoid aggregates might be a response to an abnormal marrow space rather than a cause of the aplasia, or is that a silly question?
I think it's quite unspecific. So we see that in MDS, in aplastic anemia, and it's not that the lymphocyte takes over the space. It's if you try to explain it this way. So I think it's quite unspecific. It depends on the state of the patient. Is it diagnosed early on, or do you look in the marrow early on, or during the disease course, or after therapy? So it's very unspecific.
I can just say that in some of our cases, the patients with severe neutropenia, and I'll show you later, there was marked increase of T cells. And Jen Kanakari actually did a bone marrow transplant on one of the patients with severe neutropenia, and the neutropenia persisted post-transplant and only resolved after the patient had 100% donor T cell chimerism. So when there were still host T cells left, the patient had neutropenia. You may want to comment on that, Jen.
What you've said is true, but these T cells seem to be truly pathogenic in driving the neutropenia, and we do see this association between when the marrow develops these aggregates of T cells, that's at the same time that the neutropenia is there. And we have patients who have had prior bone marrow biopsies where this is not seen, and they don't have the neutropenia yet, and it does seem to be part of the pathogenesis and disease evolution.
I was just curious for the NIH, who you've seen a ton more patients than I have. Have you done any anti-neutrophil antibody studies, antiplatelet antibodies, DATs in these patients that you feel like might be somewhat contributing to hematological manifestations, or?
In the ones we've done it on, we haven't been able to find any antibodies. Although I think that there's been reports that Isabel has where there have been antibodies noted in some patients. Is that correct?
That's correct. We found it in one patient, anti-neutrophil antibodies.
Oscar?
Thank you very much. As we know, the clinical manifestation of DADA2 patients have a broad spectrum. What is specific clinical manifestation and clinical clues vascular involvement, except vascular involvement, especially hematologic findings in childhood? What is specific hematological?
What is specific is your question?
Specific hematologic findings, except vascular involvement.
Since we had those 2 patients that had bone marrow failure, when we see a patient for bone marrow failure now, we've been checking immunoglobulins on them and kind of doing a more intense history, just looking for PAN symptoms and any other vasculitic symptoms, lividio reticularis. So I think we've expanded our, potential etiologies to include DADA2. So we're just starting with, screening for hypogam at this point, and then, really seeing if there are the lymphoid aggregates, or our patients had fibrosis as well too, seeing if there's any of those findings on the marrows too. So I feel like, and then on a few patients that we've been concerned about, maybe based on clinical history, then we've sent off the enzyme testing to Dr. Hirschfield's. But I feel like, screening for hypogam might not be pretty cheap and easy way to kind of see maybe some easy testing.
I also agree with you. Our first cohort of patients, just by definition, how we identify the disease, were patients who were younger of age. They all presented with vasculitis, fever, etc. And one feature that was fairly common, not in all of them, but in many of them, was really hypogam. So they had low IgA, IgM levels, and at that time we didn't evaluate, any other immune phenotype in these patients, but I think that's easy to screen in any patients, right, of young age. So I'm not talking about patients that have more pronounced bone marrow phenotype, but just patients that present with PAN, vasculitis, and in that spectrum, I think that that's a reasonable test to do.
Our hematologists have started to test for DADA2 if the onset is early, if there's some hypo-IgM, and any other features.
I think that it's a good diagnostic red flag for us when we look at the total DBA cohort. Probably out of all the patients presenting with red cell aplasia, diamond Blackfan anemia-like, maybe 1 to 2% of them might have ADA2 deficiency. It's not as high, but it's the diagnostic utility of it is questionable in small kids because within the first year of life, probably lots of healthy kids will have hypogamma, so it's not really that helpful. But still, we would like to do that in every patient. Yeah.
I have a comment. As I showed you in the slide, DADA2 infant, the IgA level and IgM are within the normal range. It's not high, but it's in the normal, so sometimes maybe it's difficult to discern.
I was actually fascinated with your talk. I will say that now. I mean, I've seen a lot of patients with different autoinflammatory diseases, but I've never seen so much clinical variability as we see in patients with DADA2. It's just amazing. I mean, starting from reduced penetrance, and going over the spectrum of hematological manifestations to systemic inflammation and so forth, it's incredible. So we try, as geneticists, to explain that by the nature of the mutation, whether it's loss of function, and how much enzymatic activity is preserved and so forth. And then you go to another level and you think about, well, there is and we all like to write this sentence in our review papers, there is a role for modifying alleles, right? But you have a family, of Japanese descent with the same genotype, with 2 children who present with so different phenotypes that it's truly amazing to me. And then if you take it to another level and think about modifying alleles, well, they don't maybe share all of them, but they did share significant number of modifying genetic alleles in this family. And then you think about environment again, so they share similar environment. So I really don't have, this is fascinating to me. How do you explain so diverse and distinct phenotype within one family? So the only other word that I can think of is really epigenetics. And, we are not doing any studies in that field, to show what's happening, with the epigenetic modification in gene expression, etc. But, I just thought that, your presentation of this family was just fascinating.
I was really surprised when we found the second child has a severe anemia, and we didn't do the whole exome sequence, so we don't know the second mutation or something, and we didn't do any epigenetic test, but so we don't have the answer, and yeah, we were That's my answer, and we don't have any more.
Marco, you
I
want?
have just a comment on the lymphadenopathy, splenomegaly, and cytopenia. A lot of these patients should be labeled like ALPS-like, and of course also in ALPS-like, I think DADA2 should be screened. Indeed, lymphadenopathy is a part of the classical DADA2. I have a look in my cohort. Out of 17 patients, 7 had lymphadenopathy, splenomegaly, and so on. But I can understand that there are some patients that have just lymphadenopathy, splenomegaly, and some bone marrow difficulties, let's say, and cytopenia and so on. And that is a very interesting part of the spectrum, also the ALPS-like phenotype, I think.
It may be that some of the mystery of this will be resolved once we have an idea of what is really the pathophysiology of the disease. I mean, looking at it as we are right now, not really knowing what is the whole pathway and what is the biology of this disease, it does seem, you know, incredibly mysterious, but it may be that if we knew something about, you know, what actually is the pathway, it would make some sense, maybe. Yes, Erkan.
Thank you very much for the discussion. Actually, everybody, you know, present different aspect of the disease from their perspective. Because, for example, Professor Özen, you know, described different disease course in Turkey, or other colleagues, you know, describing different things from their country. I think it's more one of the most important achievement of this meeting to describe this disease, I think. Because of this, it might be a good start to register all these patients and to describe what kind of hematological findings or what kind of other systemic involvements of these patients. Because when we check the literature, there are some case reports or case series, but there's no enough information. And Marco, you know, at the beginning of his talk, showed us a macro Eurofever study, and then they are going to actually, he did really very well work with the Eurofever study, and now he also designed a registry for the DADA2. And it might be good opportunity for us to collect these patients in that registry as a free of charge, I think. It might be a good point for this meeting.
That was an important point to me. Of course, we cannot call it Eurofever registry. We can delete, we can tell DADA2 registry that is sharing with hematologists and all the people around. But I think that a common registry that is not done by expert in bone marrow failure, expert in vasculitis, should be for the foundation, for our society, little society, very important.
Yeah, it needs to be global, both in terms of nationalities and in terms of specialties, medical specialties, so that you don't get the multiple
it's a big effort, but I understand it's a big effort, political, but I think it's for these patients, it would be very important.
Yes.
My name is Jignesh Salal. Most of you don't know. I'm a pediatric bone marrow transplanter. What my comment and question would be, I have never read, heard, or seen a disease where in literature, if the disease's age is 4-year-old and bone marrow transplant has been offered as a treatment, which literature shows 100% success rate. So that's the one disease, this is the first disease, at least in my limited knowledge. Having said that, there has also been a successful transplant by haplo donor has been described, especially by the NIH group in 2016. And it was a stop codon at 265 amino acid glycine to stop codon. And very fact that carrier donor was chosen and patient did fine, that tells me something at least in that particular mutation, following Gigi's and Pui's dialogue, whether it's dominant negative versus the haploinsufficiency, I would say it might be haploinsufficiency rather than dominant negative, at least for that particular mutation. But my question to Jane would be, when they transplanted and they noticed that neutropenia, was it the same patient, and was the donor a haplo donor as opposed to the unrelated donor? And again, my comment would be, now I know a little bit more than when I came here at 8 o'clock. The question is, we as a transplanter, should we offer a haplo donor, not knowing any of this scientific thing, but the literature says 100% success as a therapy if we don't find any suitable unrelated donor?
So the patient that Dr. Calva mentioned was the second patient with DADA2 transplanted at NIH. So you speak to the haplocarrier transplant done by Dr. Hickstein. My patient received an unrelated donor transplant. I would, based on all of the conversations we've had here, I would worry a lot about picking a carrier donor until we have more information about what it means to be a carrier and what type of consequences that have. You know, I mean, you're trying to reconstitute someone else's bone marrow using a carrier, and that's a lot of hematologic stress potentially. Yeah. But as far as transplant being 100% success, I think that's overstated.
Right, but at least if you do a naive literature review as a parent, if you are an astute parent and just look into the literature, the articles that has the description of transplant as a therapy, to best of my knowledge, I mean, nobody, and obviously there is a publication bias, positive publication bias, I understand that. But if I am a parent and I'm looking at, okay, what options my child have, and there is no unrelated donor available, I mean, that's where the question might come to us, people like us, kind of who are transplanters in the room.
Yeah, I mean, it's a potentially curative therapy, and there can be good outcomes that are reported, but there is a true risk, right, of dying with any transplant. And so I don't think it's the answer. Just, you know, you have to be careful how you approach it.
Okay. Yes, Pearl.
Last question, I hope. The DADA2 has a very broad clinical phenotype. And as we know, once the disease is diagnosed, we have a very effective treatment. And this disease is not that rare. Should we consider in the newborn screening or even carrier screening?
Well, does anyone want to take a crack at that question? Marco?
No, I talk from the rheumatological perspective, and I would be scared. I would be, of course, very happy to know if that the patient can have a vasculopathy, a stroke, because it would be very important. But I would be very, I mean, since this is a provocative, let's say, comment. I know many of my patients that are doing very well with anti-TNF treatment, just with anti-TNF treatment, now 10 years, 15 years, one patient. And of course, if you have a screening, of course, it's important to know, but what do you do? Are you going to transplant this patient? Are we ready to transplant all these patients? I think this is a relevant, I don't know, this is very naive, but, but as a clinician and a rheumatologist, I would ask to other comments on that.
Yeah, Marcin.
For diamond black fan anemia, we suggest not to transplant beyond the age of 10 years old for the real diamond ribosomopathy phenotype, because they usually, those are patients who had been transfused their whole life. They are iron overloaded, they have organ damage, so they do not do well after transplant beyond the age of 10. In the other patients who had been transplanted in our cohort with ADA2-related red cell aplasia, they were also older patients in their adolescence, in their teens, and they did very well. But those patients were a little bit different. They started their clinical presentation when they were already older, so they did not require transfusions throughout their whole life. So I think this is a different group of patients, yet the outcomes after much unrelated donor transplant in our hands were excellent.
Ivona, you want?
No, I don't have anything particular to say about, newborn screening, whether it should be included or not. I don't know. I mean, I've heard Mike said earlier today that, and we know all that ADA1 deficiency is on the newborn screening, and it's a more severe phenotype. With DADA2, we don't really know what it's going to be the phenotype.
Well, you don't have a
lifetime.
Huh? What are you going to screen for?
Yeah. Well, I was thinking more by biochemical assay,
Well, what biochemical? Oh, you mean for the enzyme activity?
Yeah, enzyme activity. That's
Boy, that's...
It's risky, right? But also the problem is that you can't really predict if there will be a phenotype to begin with, and the severity of phenotype and what type of phenotype and so forth. So it's very complicated, So I think at this point we are not ready, to suggest or advise newborn screening.
One way that possibly we could get ready, or at least to have a better idea of that, would be to on a research basis, to look at a cohort of individuals. And now as we have databases in which we have genomic sequence on large numbers of individuals, for example, the All of Us cohort in the United States, or there are equivalent cohorts in other countries, one could actually look at, 100,000 individuals or whatever, and look to see how many of them have biallelic mutations, and then see what is their phenotype. It might be we'd find that the penetrance of biallelic mutations in ADA2 is not that high, or maybe it is quite high. Mike, you want to respond?
Yeah, well, could you do that in a more focused way, maybe more biased way too, where you took the information that you have about individuals who are carrying at least one mutation and ask, prospectively over time, what happens in their families, just to enrich for newborns who would potentially have a second allele.
Another way of approaching that would be to look in the Georgian Jewish population, or possibly the Turkish population, where the allele frequencies are higher.
At least you know what are the pathogenic mutations, because most of them have, one founder mutation. I mean, this gene is so polymorphic that it's very hard to figure out really what are pathogenic and what are non-pathogenic changes. And we discussed about allele frequency, whether it's meaningful or not. Well, some of these mutations are found at the frequency 1 in 1,000. Some of them are novel or lower allele frequency. The other way to predict the pathogenicity is by algorithms, but Pew already said some of them are, or most of them are predicted to be pathogenic, to have deleterious effect on the protein function, but not all of them are also predicted. So it's all over the place. I mean, and if you look at any given cohort of patients, or even healthy control, normal population, and how many of them will have biallelic mutations in this gene, I don't know. I would be worried how to interpret the pathogenicity of this allele, even if they have two of them, because just by the fact that this gene is so polymorphic, you are likely to find a lot of people who will have biallelic mutations. Then if you find biallelic mutations, are they in cis or trans? Well, we need parents to figure out, the inheritance of this allele. So it's not that easy, to do this type of, studies. But we are doing our best. I personally feel that we are doing great progress in terms of clinical characterization of the disease, in terms of diagnostic, etc., where we are definitely lagging behind our functional studies. And unfortunately, there is no mouse ortholog, and that's why I think that people are discouraged, and nobody's really studying the function of this protein. I'm still puzzled. For example, Mike said earlier today that ADA2 deaminase activity is not that important in the extracellular space. On the other hand, we know that ADA2 is a biomarker of inflammation, so why it's there? So why patients that have whatever inflammatory disease or infection or whatever, they have high levels of ADA2 in their blood. So what does it tell us something about the function of this protein?
Well, there were two signs that we heard about: the eyebrow sign in the chipotomy sign. But now there is a new sign that I was just given, and that is the guillotine sign by Troy. And the guillotine sign means we adjourn. So anyway, that was really a fantastic discussion, and during lunch we can continue.